Words.
Okay. All right. Can y'all see the title screen there? Okay, great.
Yes.
There is an awful lot of information in this PowerPoint. So please, when you get the PowerPoint, download it and then review it. It is kind of cool. So sleep disorders and psychosis are actually rarely studied when you're looking at sleep and psychosis together. Very few articles looking at this on a clinical level. The odd thing is that psychosis and sleep issues are super, super common. And the sleep issues are enough to really increase the symptomology that the person is feeling. So a lot of the research that's done with psychosis excludes people with sleep disorders because that can up the symptoms. So that's kind of where it's also like studying psychosis without looking at the addiction piece, right? And so what we want to do with people who do have sleep disorders is to have that sleep issue become a target in and of itself. If you'll recall the START menu, socializing and target would be sleep in this case. To give you an idea of how often it's kind of overlooked, there was I'm going to Reeve, these folks here did a lovely study. Here's the demographics. 60 folks were involved in this study. And the amount of people with a sleep disorder and psychosis numbered 80%, huge. You can see all the percentages of the different sleep disorders folks do have. The number of people who actually got treatment, 8%, right? So this is a huge issue that's just kind of gone unnoticed for a long time. A lot of the treatments that we do use for sleep disorders at this moment in time is medication, right? And so some antipsychotic medication can bring on sedation, that's true. But a lot have things going on at night that keep them from sleeping, like ongoing voices and threats from voices that keep them awake. So having a sedating medication at night helps in the short term, but in the long run, it's just addiction kind of all over again. You become dependent on it to go to sleep. And so treating insomnia as a true CBT target is absolutely possible and very workable. With sleep, we do a normal formulation, just like we would do for any other issue or any client that we happen to have, but we do a specific formulation on sleep. And what we want to find out with those 5 Ps up there are, what happened? What happened that this person is not able to sleep well at night? Might be voices, might have been trauma at night. What keeps it happening? Usually a lot of us, psychosis or not, have worries when we try to sleep and we can't. And I don't know if y'all are familiar with these thoughts, but it's like, oh my gosh, I'm going to be a wreck tomorrow morning. I'm never going to be able to function. You start worrying about not functioning, and that just keeps the insomnia going, right? So for people with psychosis, the same kind of distraction avoidance can occur, only they have the added issue of positive symptoms. So we want to find out what the client has tried first. They've probably tried all kinds of things. And many of them just stay up and don't get sleep. Some of them, and we'll get to this later, have nightmares, and so actually work at not sleeping in order to avoid the nightmares. So we want to find out what might stop it, what they've tried, what you and your client think might help. Address the symptoms, the positive symptoms of psychosis, just like you would with any other client, and address the thoughts, emotions, and behaviors around the issue of sleep. So there's probably a lot of myths that this person is having about sleep, and we want to address that. And then we want to use a nightmare protocol for those who have ongoing nightmares. And, my sense is that a lot of those who have nightmares are also post-traumatic stress disorder folks. Here's what a formulation for a sleep disorder might look like. I'm not going to read through the whole thing, but, you know, historically has had trouble, voices get loud. Let's see. It's important to be responsible and do your best might be one of the messages that they have, but I'm not going to be functional because I'm not sleeping. Voices say they can kill me or my family. That would keep me up at night. Won't go to bed because of nightmares, on and on. Underlying this might be trauma, for example, or when I ever ask for help, I get yelled at, so I don't ask anybody for help with my insomnia. And oftentimes people like this will just fall asleep in front of the TV set, of course, which never does anyone any good. So there are several components for treating sleep in this population. The first session when we start working at this target is to simply explain what the treatment process is. And it's a real protocol that the client needs to understand. So we want to present the rationale for doing this to help reduce distress. And we want to give some education about normal sleep and circadian rhythm, all of which we'll get into here. There's behavioral work that needs to be done in terms of pairing sleep and a quiet environment where sleep can occur. And then we want to adjust the person's time in bed. So a lot of people will lay in bed, and you probably do this too, at times lay in bed when you can't sleep and just lay there, right? And toss and turn and lay there. And that's the kind of behavior that we want to reduce. We want to make sure that if the person's in bed, they're sleeping, not just in bed. So we use sleep logs and positive reinforcement, and we troubleshoot problems along the way. Here's a great little slide on psychoeducation. And what happens is we're going to give a prescription for how to manage the sleep. And I'll tell you about that prescription. So that prescription is reviewed frequently. We talk about the vulnerabilities for sleep. For example, if there has been trauma at night. I had a client whose hallucination was a devil that would show up on the wall at night. She'd have to sleep with a light on. You have to keep in mind if the person is working, because some of the prescription requires a consolidation of sleep, which means that they might not get quite as much sleep as they normally do. So if somebody has got a full-time job, we want to be careful about that so they're not too sleepy. Everybody needs a different amount of sleep, right? So you have to find out what's normal for this person. A lot of times there's just issues to worry about, like COVID, for example. And then there's the circadian rhythm that we all go through. If we begin to kind of change our sleep pattern, that circadian rhythm gets disrupted. Or if we have an odd wake sleep cycle because of work, for example, working third or second shift, that can screw up the circadian rhythm as well. So rules for healthy sleep is important. We want to pick a standard wake time and a standard sleep time and make sure that the room, the environment that the person is in, is clean of electronics. The thing that the bed is used for is sex and sleep, and that's it. I do, because I have trouble sleeping at times, I will read because reading makes me sleepy. So I'll read some fictional book. And for me, I've paired sleep and reading all my life. And so that works for me. So there's flexibility in this rule. If you can't fall asleep in bed, and this is true for all of us, don't stay in bed. Get up and do something else, because laying in bed is only going to worsen that worry about being able to function. Don't worry and mull over problems. That's like saying don't think about pink elephants, but if you can find a way to distract self with maybe a noise machine or a guided imagery for focus to train your brain to focus on something other than worry, then that will help. So some of that mindfulness will help. Try to avoid afternoon napping, no power naps in your office, right? And go to bed when you're sleepy, but not so early that you'll wake up at 2 o'clock in the morning and be unable to sleep. We ask the client to keep a sleep diary, and I'll show you that. for at least a week or two before we even make a recommendation about changing sleep patterns. And so, we all know that clients typically have a hard time or can be resistant to doing homework like a sleep diary. So you'll just want to maybe review that in the office, maybe see them a couple of times a week for a shorter period of time to get that sleep history down in one way or another. So treatment techniques, let's make sure the bedroom is clean. There's nothing in the bedroom that would stimulate or arouse this person other than sex, right? Going to bed and waking up time schedule has to be set, teaching about relaxation and stabilizing the sleep-wake cycle. And then what we want to do is increase daytime activity. So that's a lot of the work for like negative symptoms, right? So we want to set up some behavioral activation and help this person create some kind of a routine throughout the day. This is a 2-week sleep diary. It looks pretty complicated, but once you get used to using it, it's not. And basically we put different kinds of symbols in each of the squares. It's not too bad. C when you have caffeine or coffee. Put a line when you go to bed, shade a box that shows when you think you fell asleep, right? It's a pretty easy formula to follow. And once it's filled out, you will be able to see very easily the pattern of sleep that this person has. The structure of treatment for this, obviously this is, a number of sessions, right? We don't tackle this in one session. We do the assessment, we get the diagnosis, we do a lot of normalizing, education about sleep, make sure they understand about why the sleep environment has to be clean and why stimulus control has to be in there. Get that daytime activity going, teach relaxation, and then do rehearsal. Now the rehearsal, certainly you can do in the office and many times over. Here is a formula for a prescription. Now I'll say that for regular CBT for insomnia, for somebody without psychosis, we use what's called sleep restriction, which means that if somebody is sleeping like a couple hours during the day, a couple hours during the evening, a couple hours at night, has a really screwed up pattern, we count up the hours that they're sleeping throughout the 24 hours and consolidate them into one period of time at night. So that might only be 3 or 4 hours, right? If you're adding that all up together and they have screwed up sleep. And then slowly, so that 3 or 4 hours is going to be smack in the middle of the night, maybe not. Maybe it'll be from 11 p.m. to 3 a.m. or something like that. And slowly from there, we increase the amount of time in bed by 15 minutes each way. So as time goes by, the person gets used to being in bed and being asleep at the same time for a longer period of time. Time in bed is TIB, total sleep time is TST. We want to get the ratio to 100%. And sleep restriction therapy is standard, right? The goal is to get 100% ratio. We very rarely ever achieve that, but if we're getting 80 or 90%, that's pretty good. Here's a diagram of circadian rhythm issues. So there's folks who end up going to sleep, really early in the evening. Maybe they go to sleep at 5 or 6, and of course they wake up at 2 or 3 o'clock in the morning and can't get back to sleep, and there's nobody to play with at that hour, particularly if you have psychosis, and that's kind of a dark hour, right? So going back to sleep is usually not going to happen. The delayed sleep shift, this is what I most often see in clients, is where they stay up way late and fall asleep on the couch, and then they sleep well late into the next morning. Yeah, people, and this is usually with negative symptoms who have hypersomnia, and they're just kind of laying in bed and laying around all the time. And then there's a few folks who just really have an erratic sleep schedule, and it's always been like that for them. So for standard CBTI, as I said, we work at consolidating sleep and move out. For psychosis, rather than consolidating sleep so much, we work more at activity scheduling and getting them active enough to be tired so that when evening comes around, they're actually going to sleep. So building a routine for this person is going to be really important. Exercise is, nearly paramount of some sort, walking, something, and really putting some structure to the day. I know that's a tall order, but if you've got somebody who's not sleeping and it's increasing their symptoms, there might be some real motivation there, particularly if they're very scared at night with basis. So we want to make sure that we have the right sleep disorder diagnosed and diagnose the circadian rhythm, right? And follow those steps, right, on the left-hand side of that pyramid that we just looked at, and just simply continue practicing that until it becomes routine for the person. We want to get 7.5 to 9 hours of sleep is usually what we need. Medication is helpful, but not for the long term. If we need medication, we use medication, but the goal is to slowly wean off anything that's prescribed specifically for sleep. Rather, we use stimulus and control rather than medication to try to get that sleep to happen. For psychosis, we want not to use sleep restriction in any kind of a huge way. We might use it just a tiny bit, right? But not more than that. You can suggest going to bed a little bit later, waking up a little bit earlier. No computers, no phones, no anything, no games in the bedroom at all. So we're treating for the sleep disorder. And along with that, with psychosis, there's a whole bunch of other symptoms, cognitive, negative symptoms, delusions, hallucinations. And we treat those just like we treat any of these symptoms in psychosis. And, we're all fairly versed at that. So here's what happens if you're laying in bed and you can't go to sleep and you're rolling around and you stay there. You're not going to go to sleep. Get up and do something really horribly boring. Ironing, folding your clothes, something as boring as you can possibly imagine, and just keep doing it until you get tired, right? Relaxation and mindfulness is fine, but get up out of bed, because if you stay in bed or your client stays in bed, they pair being restless and awake with the bedroom, and we don't want that pairing to happen. Nightmares are very, very common with psychosis, as you can imagine, for a lot of different reasons, trauma, hallucinations. And people don't generally talk about them. They don't spontaneously say, hey, I've got these nightmares going on. So you're going to have to ask. And I would suggest that that be part of every assessment that we do, seeing as that sleep disorders are so prevalent and so severe in this population. And nightmares are part of that, right? There's a lovely nightmare protocol, and here it is. And it's, you'll be able to use this, right? And basically that's write down the nightmare that you're having, and including the ending that occurs in the real nightmare, and then have the client come up with a different ending to that nightmare. And usually some kind of a positive thing. Maybe they fly away, maybe they defeat the hallucinations or whatever protagonist is in their nightmare, right? And the goal then is to read through that new nightmare scenario at least 3 times a day, monitor how often the nightmares are occurring, and adjust the ending as needed, and keep working with relaxation and mindfulness. I've used this, it does work. There's also some medication to help with nightmares, and that might be needed as well. But this would be your first route here of treatment. A lot of people with psychosis who have sleep issues get disoriented in a dark room, or even a dimly lit room. And so when they're working on this, putting signs around the room to remind them of what things are, because they can wake up and see the bureau or the lamp and automatically there is a shadow or something with eyes lurking in the dark. So putting the signs are good. I'm here, I'm safe. This is the lamp. This is the nightstand. Deep breathing and relaxation. Okay. Do that thing, look, point, name. If you'll remember that activity, can really help reduce arousal in a situation like that. Again, have them lie down when they're sleepy. Leave the bedroom if they're awake more than 15 minutes and return to bed only when you're sleepy, right? Keeping the fixed wake and sleep time there. Okay, it's a pretty quick and dirty talk on sleep disorders. Assessments. Here are some great assessments that you can use to help you diagnose the kind of sleep disorder your client may be experiencing. I have here included in handouts. I don't have these handouts for you, but here's, the great little links here that you can use. And the GAD-7 is great for worry and restlessness type issues. For those of you who do have insomnia or work with people who do have insomnia, this is the prescription to use for straight CBTi. And that is get the total hours of sleep, consolidate them to a period of time in the middle of the night. You want to divide the total sleep time by total time in bed, multiplied by 100, and we want to get to 90%, which is what we think of as effective sleep. So you can imagine if we got a bus driver, for example, who's having insomnia, you got to write that person off, right, for work, because you might be consolidating into a very small amount of sleep. But this works for you guys too. So for any of you that happen to have a sleep disorder or can't get to sleep at night, hopefully this will help you as well. I was trained at Penn State by Michael Perlis. There's a book. This book is great. It gives you everything that you need to know about regular CBTi. And if you'd like further information, please just give me a call, write me, and I will send you what I've got and try to provide some more resources for you if you need. And that's what we have. And so I'm curious if there are any questions.